Good morning. Myself Dr. Sunisha Karthik, working as a cardiac physiotherapist in UNMICRC Institute of Cardiology and Research Center. Today, under continuous physiotherapy education, my topic is development delay with perspective of congenital heart disease. So, the contents of my topic is, first of all, we will discuss normal typical development, primitive reflexes, causes of development delay, how congenital heart disease affects brain, warning signs of development delay, screening of development delay, and approaches towards the development delay. So first of all, what is the definition of development delay? Development delay refers to a child who has not gained the development skills expected of him or her compared to others of the same age. There are four main domains of development delay, or which may occur in the areas of motor function delay, speech and language delay, cognitive delays, social, emotional and behavior delays. So if there is any one delays in any one of these areas, the child will be called in the aspect of development delayed child. And there is another term, global development delay, which means a young child has significant delays in two or more of these areas of development, then that is called global development delay. So we will discuss normal typical development in the areas of gross motor, fine motor and mental development. So at the gross motor, at birth there will be flexion attitude, means the upper limb and lower limb will be at flexion. At 3 months there will be proper head support. 6 months the baby can sit momentarily supported by his or her arms. 8 months the baby can sit alone without any support, back straight. 9 months he can creep or crawl whatever he likes. Gross motor again at the age of 12 months, walk supported with one hand held. 13 to 15 months walk alone well. 18 months he can sit himself in a small chair, ascend the stairs with one hand held. 24 months he can run well, climb up and down the stairs alone with one step at a time. 30 months he can climb the stairs with alternate feet. And again at 3 years he can ride and pedal the tricycle. 5 years jumping on one foot is possible. And now comes the fine motor development. At the time of birth, the baby can blink to the flashing lights. 1 month there is following of the moving objects. 3 months baby can spontaneously open his or her hand. 6 months transferring the objects from hand to another hand or even to the caregivers. At 8 months there is a pincer grasp, that is called if the baby can hold the objects in with the help of 1 or 2 fingers. 12 months releasing the object to mother on request. 18 months build the tower of 3 cubes and he can even feed himself by a spoon. 24 months build the tower of 6 cubes. 30 months build the tower of 9 blocks. 5 years the baby can even draw a man or sketch a man. Mental development, social and speech, at the age of 2 months he begins to smile at people. 2 months he can even put his hand on mouth and he can do the sucking action. 4 months smiles spontaneously, especially at people. 6 months knows familiar faces and begins to know if someone is a stranger. At the age of 1 year the baby would be having his favorite things. 1 year again he can hand you a book whenever he wants to hear a story. That means they can express themselves. 1 year he will put out arms or legs to help with the dressing. 18 months likes to hand things to others as play. He can enjoy playing with others. 18 months whenever there is a new situation they may cling to caregivers or mother. 2 years the baby can copy others, especially adults and other children. Get excited with other children, likes to play with others. 3 years dresses and undresses well. 4 years cooperate with other children, that means he likes the group activities. 5 years wants to be like friends and wants to be with friends. So these are the normal development, typical development, and now we can discuss the primitive reflexes, that is called neonatal reflexes, which is very helpful for baby to survive. The primitive reflexes are the reflex actions arising from the central nervous system in neonates in response to a particular stimulus, which is later on suppressed by the development of frontal lobes. Assessment is very important if there is a development delay in infant. Normal reflex means normal CNS. If there is absent reflex, that means there is a CNS injury or hemorrhage. If there is exaggerated reflex, that means there would be CNS irritation. If there is a persistent reflex, that means there would be a condition of cerebral palsy or mental retardation. So now I am going to discuss some 5 or 6 reflexes primitive, which is very important for the baby to survive. And these are: first, sucking reflex. Onset is 13 to 16 weeks during gestation. It integrates at 12 months of age. Stimulus is elicited whenever we place one finger at the upper part of the lip. The baby closes the mouth or do the sucking action. So, and then the rooting reflex, onset is 28 weeks of gestation, integrates 4 to 6 months of age. The stimulus is elicited whenever we place one finger at the cheek of the mouth or at the corner of the mouth, and the baby turn their face towards the finger and tries to put inside the finger inside the mouth. So these sucking and rooting reflexes is very important for baby to feed themselves for their breastfeeding. Now comes Moro reflex. Onset is at birth, integrates 3 to 4 months around. This is also called starter reflex. It is the stimulus is elicited by the flashing lights or intense sound, loud noise. When the baby gets startled, the action would be extension of the upper limb and then followed by the flexion of the upper limbs and lower limbs. The baby will even begin to cry for some time. Then comes tonic labyrinthine reflex. Its onset at the time of birth, integrates around up to 4 months. Here, this reflex is very important for making the head in control. This stimulus is elicited whenever we place the baby in supine position. During neck flexion, there will be same criteria of the upper limb. There will be same flexion of the upper limb in the neck flexion. Extension of the neck, that would cause extension of the upper limb. The pattern would be same as continuous with the neck flexion or extension. Same goes in the prone position also. If there is neck flexion, then there would be upper limb flexion. If there is neck extension, then there would be upper limb extension. Then comes gallant reflex. Onset is at the time of birth, integrates around 3 to 9 months. Here, the stimulus is elicited whenever we stroke the lateral part of the body, then the baby will side bend towards that side. Okay. Then comes palmar grasp reflex. Onset is at the time of birth, integrates around 5 to 6 months of age. Here, whenever we places one finger or object inside the hand of the baby will grasp that object or the finger. Stepping reflex, onset is at the birth, integrates around 2 months. Whenever we carry baby or places their foot over the surface, then the baby will do the stepping action automatically. Then comes asymmetrical tonic neck reflex. Its onset is 37 weeks gestation, integrates by around 4 to 6 months. Here, the stimulus is elicited if we rotate the baby's face to one side, then there would be extension of arm and leg on the face side, flexion of arm and leg on the skull side. So this is very important to promote the hand-eye coordination. Then comes last, symmetrical tonic neck reflex. Its onset is around 4 to 6 months. It integrates around 8 to 12 months. Here, if we place the baby in the crawling position and make the baby flex the head, then the arms will flex and the legs will extend. And again, in the crawling position, extend the head, the arms extend and the legs bend. This is very important for starting the crawling position, milestone of the baby. Causes of development delay. Here comes prenatal factors. Genetic factors. Prominent genetic factors include chromosomal abnormalities, example Down syndrome, single gene disorders causing disorders of brain formation. There is maternal factors also. If there is maternal drug or alcohol abuse, pregnancy-induced hypertension, hypothyroidism and malnutrition is there. If there is acquired infection, example starch, which have severe impact on fetal physical and brain growth. Neonatal risk factors are the baby is having low birth weight, if there is neonatal seizures at that time. Post-neonatal factors, nutrition factors, if there is nutrition deficiency, acquired insults to brain after surgery or conversion. Endocrine factors, if there is associated impairments or conditions like congenital heart disease, then also it can impact the fetal brain growth development. So now the main core part is that how does congenital heart disease affect the brain? So it may affect the brain in several ways. First, the heart is the organ which pumps blood that carries nutrients and oxygen to the brain to allow it to grow and develop. So even in some types of congenital heart disease, it may reduce the amount of blood reaching the brain or the oxygen content of the blood. So in both the cases, there is reduction in the blood flow and oxygen content which may impede or stop brain maturation. So indeed, Full-term babies with some type of heart defects have brain maturity that is about 1 month delayed, that is similar to those of premature babies born at 36 weeks. Second, brain injury may also occur in congenital heart disease. Already the brain is immature, which increases the risk of brain injury with stresses such as labor and delivery, blood pressure instability or infection. So most vulnerable part to injury is the white matter part, which can impair motor and cognitive systems critical for development and learning. So in this figure also, there is a congenital heart disease. It causes cyanosis, then it causes inflammatory reaction, which cause the neural cells death and brain damage. And again, even in the congenital heart disease, if there is immature central nervous system, the baby would be having low IQ. Again, children with CHD may also experience acute events such as cardiac arrest that may be post-operative also. Depending on the severity, cardiac arrest may cause widespread injury or more limited injury to the brain structures that are more sensitive to oxygen and nutrient deprivation. So if the baby is undergoing bypass operation, cardiopulmonary bypass, then the factors which are responsible are, if there is reduced blood perfusion, then there is reduced hemoglobin, it causes neuron damage and again brain damage. And if there is hypothermia or hyperthermia, the hyperthermia may cause microemboli or thrombolus to form, then it can again cause organ damage. So this is the way how the organ or brain cell damage can occur during operation. Some type of CHD also allow the blood clots to form and travel to the brain, locking blood vessels and causing stroke. Even in cardiac operations or cardiac catheterization can also be complicated by stroke. So although children's brain have a remarkable capacity for recovery, but these injuries may impact communication between different brain systems such as the visual and motor system, or directly damage regions of brain important for specific tasks. So the children which are higher risk of neurodevelopment impairment are the neonates who are requiring open heart surgery, and children with other cyanotic heart lesion which doesn't require the infant heart surgery right now at this time, but later on they may require, but their development delay will occur. Congenital heart disease combined with any of the following: prematurity, development delay, suspected genetic abnormality or syndrome associated with development delay, history of mechanical support. If the post-operative they have given ECMO support or ventricular assist device, it can also lead to the development delay in certain cases. Heart transplantation, cardiopulmonary resuscitation, if the patient has undergone CPR, then also the brain damage can occur at some times. Hospital stay longer than 2 weeks after surgery. If there is perioperative seizures, abnormal findings on brain imaging or small head circumference is there. Then the most common syndromes associated with CHD, the most common syndromes are DiGeorge syndrome, Turner syndrome, Williams syndrome, Down syndrome. So if we see the DiGeorge syndrome, the characterization of the baby would be presented with a cleft palate, there would be hooded eyes with a small ear. Even in the Williams syndrome, there is a large ear, full cheek, small jaw, upturned nose, wide mouth will be there. In the Down syndrome, there is upward slanting of eye, flat nose and face, thin upper lip, opened mouth with protruding tongue. There would be short neck, there will be floppy joints, and there will be laxity of the joint, small ears, excess knuckle skin. Even in the trisomy 18 Edward syndrome, there would be overlapping of finger, low set ears would be there, decreased muscle tone again, small physical size would be of the baby. Heart along with the lung abnormalities are there. The patient would be presented with a club fit deformity. So these are the scenarios where we can judge the patient may or may not have the congenital heart disease. Then how does the congenital heart disease affect the child's physical development? Children with congenital heart disease tend to grow and develop a little more slowly than the healthy children. They may also end up being a bit shorter than the normal. So this is particularly true with the children with cyanotic congenital heart disease and congestive heart failure. One study found that children with CHD have a risk of severe motor problems 11 times that of school-age children without any known heart failure. Another study has seen the cause of fine motor deficits in just half of the children with CHD 12 to 18 months after neonatal open heart surgery. There is reduced motor coordination which is seen mostly in the transposition of the great arteries. Children with HLH syndrome, that is hypoplastic left heart syndrome, tend to have weaker visual motor integration capabilities. Some children even showed reduced muscle strength and impaired balance performance, so they may require regular rehabilitative program or strengthening exercises to regain their muscle strength. Now comes the warning signs of development delay, which we have to make it concerned about that. At the age of 1 week, the patient gross motor area would be if there is absent motor reflex, poor feeding or conversion is there, then you have to be alert. If at the age of 6 weeks there is no face regarding in the social area, then you have to be alert. At the age of 3 months, the fine motor area in clutched hands is there, and even the social area there is no smiling responsively. At the age of 4 months, there is poor head control, no interest in own hands. 6 months, the persistent motor reflex is there, and there is no interest in toys. If these all are seen in the kids, then they must be having delayed development, and you have to be concerned about that. At the age of 9 months, the baby is not sitting alone or not reaching for the objects. At the age of 11 to 12 months, if there is no pincer grasp, poor attention span is there. At the age of 18 months, the baby is not walking without any support. At the age of 2 years, there is aimless overactivity. At the age of 3 years, baby cannot draw the circle and he cannot obey the command, or he doesn't come for the play when asked. The baby doesn't know their name or cannot recognize the colors. At the age of 6 years, there is no useful speech, or baby cannot tell their favorite cartoon character's name, or baby cannot say the recognition of colors. Then you have to be alert. At these times, the baby must be having any development delay, and you can take it to the particular clinical setup for that thing. Then comes the screening of development delay. This is very important in the clinical setup because it is a quick and general measurement of skills. Purpose is to identify children who are in need of further evaluation. So there are 2 or 3 skills which I am describing here. Denver development delay. It's a tool that combines direct observation and parental report. The tool consists of 125 items organized into 4 development domains, namely gross motor, fine motor, adaptive language, personal and social. Here you can get the brief idea of wherever the development delays are lacking. Child Development Inventory. Second, it is also known as Minnesota Child Development Inventory, was created to provide a systematic standardized method for parents report on their children's strength, problems and present development. It measures child's development in 8 areas, namely social, self-help, gross motor, fine motor, expressive language, language comprehension, letters and numbers. Here again it consists of 300 item booklet, and you have got the answer sheet for the parent to complete. Then comes Baroda Development Screening Test. It's a screening test for motor mental assessment of infants. Can be used by the child psychologist rather than physicians, and can be applied up to 30 months of age. Kit is commercially available for it. Then comes Trivandrum Development Screening Test. It is a simplified adaptation of the Baroda Development Screening System, and it can be administered in 5 minutes by a health worker. Recommended to be used as a mass screening test. Now comes our approaches for the development delay, whatever interventions we are doing. First of all, counseling and training of family, education programs, medical services, nursing services, nutritional services. Then comes physical therapy, occupational therapy, psychological services. So first of all, I'll discuss about the physiotherapy approach. The aims for giving the physiotherapy is for achieving development milestones such as rolling, sitting, crawling and standing, increasing the muscle strength, stretching of the stiff joints, improving balance and coordination, promoting normal patterns of movement, achieving maximal potential, improve the quality of life and promoting independence with everyday tasks. Here I am going to discuss some of the latest approaches which everybody is using at the clinical setup. So first of all, neurodevelopment approach. It is also known as Bobath approach, focuses on facilitating normal movement patterns. It uses specific handling techniques to inhibit the abnormal movement pattern and then encourage more functional movements. It aims to improve individual control, coordination and balance. Second is sensory integration. Those kids who are having sensory issues, in them their focus is on addressing sensory processing difficulties often seen in individuals with development delay. By providing sensory experiences through play and structured activities, therapists can help regulate sensory responses, promote attention, and improve the motor planning. It aims to help individuals integrate and respond appropriately to sensory information. Here are the most used sensory equipments which everybody is using, that is swings, trampoline, balance board, everything. Then task-oriented approach, it focuses on improving functional abilities by practicing specific tasks or activities that are relevant to the individual's daily life. Here therapists break down complex tasks into manageable steps and provide support and guidance as needed to help the individual develop the necessary skills. Fourth is strength-based approach. This is emphasized on building strength and endurance in individuals with development delay. Here, therapists use exercises and activities that target specific muscle groups and gradually increase the intensity and complexity of the task. So, the babies can enhance their motor skill and functional abilities. Fifth is home exercise program, which is very much important because after having all the therapy sessions at the clinic or other areas, there should be complete consistency and repetition of exercise at home so that it can help reinforce the gains made during the therapy session. And it consists of specific exercises, activities, and strategies that can be incorporated into the individual's daily routine. Now I am going to discuss, apart from physiotherapy approaches, there are some other therapy which are mostly used. First is occupational therapy. It focuses on enhancing the child's ability to perform daily activities and promote their independence. They work on fine motor skill, self-care skills such as dressing and feeding, sensory integration, cognitive skills, and social skills. Then comes speech and language therapy, which is very much important. It helps the children improve their communication skill, including speech production, language comprehension, expressive language, and social communication. In this, they use various techniques such as play-based activities, communication boards, and assistive communication devices. Third is applied behavior analysis. It involves breaking down skills into smaller steps and using the positive reinforcement to encourage the desired behavior. It uses the behavior principle to teach new skill and reduce the challenging behaviors. So this is very effective for children with development delay, particularly those on the autism spectrum. Then comes fourth, social skills training. Here children with development delay may struggle with social interaction and social cues. So it focuses on teaching appropriate social behaviors, including turn taking, sharing, making eye contact, and understanding emotions. So here role playing, group activities, and social stories are commonly used in this approach. Cognitive behavioral therapy. Next, it's a psychotherapeutic approach that helps children develop problem-solving skills, manage emotions, and improve their thinking pattern. It can be beneficial for children with development delay who may experience difficulties with executive functioning, emotional regulation, and adaptive behavior. Then comes last, play therapy. It's a therapeutic approach that uses play as a means of communication and expression. It is mostly effective with younger children. Play therapist creates a safe and supportive environment where children can explore and work through their emotions, social skill, and cognitive abilities. So last, the combination of various techniques based on individual strength and areas of challenge can maximize the effectiveness of the intervention. And the qualified physiotherapist will conduct the thorough evaluation and develop a customized treatment plan based on individuals' unique requirements. So that's all. Thank you.